The algorithms plus judgment. And algorithms doesn't replace judgment. It gives a safe default. Once you know the standard pathway, you can clearly explain why you are deviating it from complex case and then document the reason. That balance, following the algorithms, but knowing when and why individual care is what defines good obstetricians. Cervical efficiency, this is the topic. Suspect the diagnosis. History of one or more prior unexplained mid-trimester pregnancy loss, presence or absence of risk factors, confirm gestational age, and document fetal well-being. If low clinical index of suspicion, then discuss the option of cervical cerclage, but do not recommend. Discuss the progesterone supplementation. Serial cervical length is needed. If it remains normal, then routine care is to be done. But if the cervical shortening noted, discuss progesterone supplementation. Consider revisiting the option of cervical cerclage. NST to exclude uterine contractions. If contractions are there, admit the patient to the hospital. Fetal fibronectin, bed rest, pelvic rest, antenatal steroids. And MFM and ICU consultation should be done. Then if no contractions, outpatient management, serial cervical length, weekly, 1 to 2 weeks, fibronectin should be done. Consider bed rest, pelvic rest, and consider antenatal corticosteroids. But if there is a high clinical index of suspicion, recommend prophylactic cerclage, review risk and benefits, obtain written consent, discuss progesterone supplementation, patient decline cerclage, then return to serial cervical length monitoring pathway. But if patient consents to give the cerclage, then exclude the contraindication and cervical cerclage placement should be done. Place cervical cerclage and technical concentration include type of cerclage and technique and use of tocolytic agents and antibiotics. Then subsequent follow-up needs a weekly or bi-weekly visits, serial cervical length, ask about the complications, pelvic rest, no tampons, intercourse. Then remove the cerclage electively at 36 to 37 weeks. Consider earlier removal if there are contractions, bleeding, or throb. So this is the how to suspect diagnosis and to find out. This is the algorithm which we should use for the cervical insufficiency.